Hi, everyone. This is John Mandrola from the Heart.org Medscape Cardiology, and I'm here in Amsterdam at the European Society of Cardiology meeting, and I'm with my good friend, Dr. Dheeraj Gupta, who is a prolific academic electrophysiologist at the University of Liverpool, has extensive experience in AFib ablation, and we're here to talk about the ADVENT trial. This is a randomized controlled trial looking at two technologies to ablate atrial fibrillation. One is the standard thermal ablation, which could be either RF ablation or cryoballoon ablation, and the active arm was this technology called pulse field ablation. Dheeraj, welcome.
Thank you. Thank you, John, for the invitation.
The trial is a randomized controlled trial of the two technologies looking at efficacy and safety. It was a U.S. trial, and it was done for FDA approval because we Americans don't have PFA. Now, you in the UK, you have used it.
That's correct, sir. So we've had it about 18 months ago, so we've got some experience of it. There are some centers in Germany who've got slightly more experience than us. So yes, it has some advantages and disadvantages that we can discuss.
Okay, great. And so the trial results, primary endpoint was really an efficacy endpoint, and they looked at it in a non-inferiority design. And really, to keep it short, both technologies, the standard thermal and PFA, performed equally well in efficacy. Do you agree?
Yes, so that's been our clinical experience too. But in terms of efficacy, pulse field ablation is equivalent to thermal ablation, such as cryoballoon and radiofrequency. I think the main benefit or supposed benefit of the technology was in the safety bit.
Let's first of all talk about efficacy. Did you expect there to be any difference between regular thermal ablation and this PFA technology?
Based on our clinical experience of the last 18 months, no, I did not, because that's been our experience that they both are equally effective. Having said that, if you go based on some of the initial studies published in the field of pulse field ablation, especially the invasive remapping studies, which showed over 90% durable pulmonary vein isolation, there was some hope that that would translate to better clinical results than the ones that we saw today.
Okay, and before we get into safety, which is the big deal, let's just talk about what exactly PFA is and what does it mean, pulse field ablation?
So pulse field ablation is a novel energy source. It's essentially electroporation. It's very different from the conventional thermal sources of energy, whether it's radiofrequency, cryo, or laser. All of those energies essentially work by, as you know, heating or freezing the tissue, which means that there is a theoretical risk of ancillary damage to structures surrounding the heart, such as the phrenic nerve, esophagus. With electroporation or pulse field ablation, it's very cardioselective. Unless you greatly exceed the recommended doses, in the doses that we are supposed to use, it is cardioselective. So it almost eliminates the risk of damage to surrounding structures, such as the esophagus and phrenic nerve.
Would it be fair to say that it's almost like delivering shocks through a catheter to the tissue, and it creates pores in the cardiomyocytes, but not other things?
Indeed, that's absolutely the way it works. So, so it does that immediately, and then there is a period of a few days, few weeks when fibrosis sets in, and that's when the full effect of the ablation, if you like, is manifest. Okay,
so the theoretical advantages are safety, and it presumably doesn't cause atrial esophageal fistula, phrenic nerve, and like we were talking before, things like atrial esophageal fistula, it's extremely rare, but I think it's on all of our minds because these are 50, 60-year-old people who have a non-life-threatening disease. And so it seems like a very rare complication that we really want to avoid. And if PFA can avoid that, that's certainly an advantage, correct?
Correct. So not only are these complications extremely rare, but as you say, they're very serious and you want to avoid them, but also when in the process of trying to avoid the complications, you are making the procedure more complex, either by adding esophageal temperature monitoring or by pacing the phrenic nerve to avoid phrenic nerve palsy. With pulse field ablation, you don't need any of that. So not only does it improve the safety of the procedure, but also reduces the complexity.
Okay, and another advantage of PFA, potential advantage, is that it makes the procedure faster. And we did see this in the ADVENT trial. Dr. Reddy said that the procedure times were significantly lower. But from a European perspective, you think it could be even lower than what the Americans did in their first regulatory trial.
Correct. A couple of things to say to that. First of all, these were operators who, whilst being very experienced in AF ablation, were totally naive to this technology. So they were literally getting their hands on the catheter for the first time. And that might explain the fact that the average procedure time was 100 minutes in this trial in the pulse field ablation arm. Also, I noted that a quarter of the patients required CTI ablation for flutter. So that would have added the procedure time.
CTI ablation being atrial flutter ablation.
Indeed.
Okay.
Whereas if you were to look at clinical experience with pulse field ablation in the UK, Germany, procedure times are now well lower than 60 minutes.
I've been to Germany. I've seen ablation in the UK and in Scotland and in Poland in cost-constrained systems, and it is very different than we do in the US. And how exactly do you get a AFib ablation down to 38 minutes? Because we're in the 60 to 90 minute range, and that's going pretty fast.
Yes, that's right. So I think nowadays most of the work done in Europe is to improve the efficiencies and the throughput through the lab. You really don't need to make the procedure much more complex than it is. So I think it helps that a lot of the cases are not done in the full general anesthesia. So you can use propofol to really reduce the procedure time. You don't really need transesophageal echo or intracardiac echo in Europe, as you've seen in your experience. So that reduces the procedure time dramatically. The other thing to say is, obviously in the trial, they had a mandatory 20-minute waiting period, which you don't need in clinical practice.
Now, let's move to safety. I've got the paper pulled up here. They did have safety endpoints. And again, we could go into the details, but the short story is that they were very similar. There were no major complications such as atrial esophageal fistula. There were phrenic nerve palsies, fairly similar. Is that your impression that the safety was pretty similar?
Yes. Thankfully, atrial fibrillation ablation is very, very safe anyway. So it's extremely difficult to prove in a relatively small trial of 600 patients any potential benefits in terms of safety. And that's what the trial showed. Both are equally safe. Also, the complications that pulse field ablation eradicates are thankfully extremely rare in themselves. So that would not have been expected to have shown up in the trial data. Most of the complications in AF ablation are related to access from the groin and access into the left atrium. Either groin complications and tamponade are not expected to be any lower with pulse field ablation as compared to thermal ablation.
There were some pretty severe complications in the trial. And again, they were not specific to the technology, more specific to the procedure itself, which is remarkable because, and we were talking about this, the operators in this trial are like, they're the best. They're very experienced. And at least in the US, many centers are low volume centers. And I guess, what is your impression of this technology in the hands of a low volume operator? Would it be an advantage or potentially a disadvantage?
I think it's a huge advantage. Anything that makes the procedure less complex and quicker is, in my mind, a good thing, because it then opens up the field to a higher number of operators with no increased risk to the patients. As we know, with radiofrequency ablation, there's quite a steep learning curve. And many operators have to do hundreds of cases every year just to keep their hand in. With cryoballoon, a lot of those issues were addressed already. So the learning curve was shallower. And in my experience with pulse field ablation, it's narrower still. So it's much easier to get really good with pulse field ablation compared to some of those legacy ablation techniques.
All right. I want to ask you now, we're a few more minutes left. There was a lot of excitement about PFA when it first came into being. And what was your general feeling of the, I guess, the excitement, not excitement, sadness, happiness at the trial presentation?
Okay. Because I had my experience with the pulse field ablation the last 18 months, perhaps the overall result was not a surprise to me. I could sense a bit of disappointment in the room when it emerged that the success rates were not better than with thermal ablation. I think this represents the flaw in terms of what can be expected with pulse field ablation. It's a new technology. It'll only get better. Our experience with it will only increase. So I still have hope that in the future, our success rates will improve with this.
Yeah. I think that we always see this in our field, right? There's iteration and this is the beginning. This is a first company's catheter. It's an early catheter. I can envision a scenario where it gets put onto other catheters that we can use. We don't have to switch out, and things just improve and iterate. I mean, do you get that feeling too?
Indeed, a lot of research is going on behind the scenes, as you would expect, in pulse field ablation. Every big manufacturer is strongly backing pulse field ablation, not only in terms of large footprint catheters like the pentaplan catheter studied today, but also in focal catheters, which were earlier used for radiofrequency. So potentially, pulse field ablation will be applicable to more conditions than just atrial fibrillation. I think it's only a matter of time.
One of the things that I'm always harping on is that iterations of technology are great, and I'm glad that we have better tools. We certainly do have better tools, but I'm not sure it moves us in a direction of learning and understanding atrial fibrillation any better.
Well, I share your thoughts on this. We seem to have reached a plateau when it comes to our understanding about AF, and hence our success rates with AF. Everywhere you look, success rates are about 70-75%. We've never really been able to improve that much beyond that. And that is a disappointment which all of us share in the EP world. But if we can get the same success rates with a quicker and safer procedure, I think it'll have to do for now.
Excellent. Duresh, thank you so much for talking to us. It's been great.
It's a pleasure. Thank you, John.